I'm Steve Flynn. I'm Steve Flynn, the founding director of the Global Resilience Institute. And one of the themes that we've really been trying to advance with the work of the Institute since we were launched at Northeastern in 2017 is the idea that resilience is not about bouncing back from a disruption or a shock or a disaster, but should be about bouncing forward. It should be about adaptation to the world we're in, so that we can thrive in the face of some of these challenges. And then a key element of that is the idea of design, that we should be thinking about how we bake in resilience into the design of the key systems and the communities that we live within. And so this, not surprisingly, brings us in very close connection with some cutting edge work that's being done in the world of architecture, and some of which we have some very distinguished scholars here at Northeastern University who undertake such efforts. And among them is our own Professor Sarah Carr, who is an assistant professor of architecture and the program director for the Master of Design and Sustainable Urban Environments here at Northeastern. Sarah is a licensed architect. Her work and research is on the connections between urban landscape, human health, and social equity. And she has been recognized by the Graham Foundation and the Mellon Foundation and the National Science Foundation. And we're excited. She just has out a new book published by the University of Virginia Press on the topography of wellness, how health and disease shape the American landscape. And we're going to get to hear a lot more about that here in the next hour. So with that introduction, Sarah, please jump in.
Hi, thanks, Steve, and thanks, Kathleen, for the introduction. Thanks to everybody joining us here today. And we're a small group, so I hope we can have a conversation after the presentation is done. Before I start the talk today, I just wanted to recognize that I'm currently speaking to you from my home, which is just south of Boston, appropriate for a talk about landscape and health, and I will get into this a little bit more later, but I want to thank and acknowledge that I sit on the occupied territory of the Wampanoag and Massachusetts tribe, and just want to express my gratitude for the stewardship of the land, which fosters all of our health, despite the generations of injustice inflicted upon the tribe. So the topic of my talk today, and really the question I think that drives a lot of my work, is basically this: how does the design of buildings, landscapes, and the public realm heal or harm us? Just to give a little bit of biographical background on myself, as Steve mentioned, I am a licensed architect. So I graduated with my architecture degree from Tulane University. And I was working at an architecture firm, and I was working mostly doing healthcare facilities in New Orleans. And so that's when I started to get into this realm of what we call evidence-based design. I found it really interesting, the amount of research that happens in the healthcare sector of how the design, how color choice, how layout of hospitals can have this really immediate effect on health outcomes. And now the other part of that story, though, is I was working in New Orleans when Hurricane Katrina hit. And so I myself evacuated for about 6 weeks. I came back. Luckily, my house was still intact. And obviously, there was lots of work to be done if you were in the architecture and construction sector. So mostly, again, immediately repairing a lot of those healthcare facilities that we had been working on before the storm. But I was also doing recovery with FEMA under my job. And then at the same time, attending a lot of community meetings and thinking about, okay, what does post-Katrina New Orleans look at? And I started to hear lots of people saying, we're going to build back greener, healthier, all these ostensibly good values that we usually hear in these meetings. And I started to wonder, we have so much research in the healthcare sector about health design and health outcomes. And I started to get interested in what was the application of that research if you look at an urban planning or landscape scale. And that's what led me to actually go back to graduate school to get my master's of landscape architecture and then PhD in environmental planning, and really exploring this idea of health on an urban scale. So next slide, please. Thank you. So in an effort, though, to really understand how our present day landscape shapes our health, I knew I had to first understand the history of shifting ideas about public health and the public realm. At this time, there was a lot of emerging research on place and health. Many of you listening on this call are probably familiar with it. And at the time, it was being positioned as new research, but I knew there was this history, obviously from landscape architecture school, knew about the history of Frederick Law Olmsted, who he himself had a public health background, and how much it influenced his work. And so there was somewhat like a chapter-long detour in my dissertation where I wanted to explore these historical movements. And that, in effect, is the book that I'll be talking about today, which is going to be out October 5th, 2021 from University of Virginia Press in about 2 weeks. A caveat, I'm not a historian. I am a designer, albeit an academic one. And the movements I want to explore is I wanted to flesh out our thinking about how places are formed for health and how that history has accumulated over time in response to different epidemics and pandemics. So oddly enough, as someone who has been looking at how health and disease has formed the urban landscape for about a decade now, and I should mention I turned in the book manuscript actually in February 2020, so right before COVID hit the United States. And so COVID itself is not specifically covered in the book, although obviously it figures into the introduction and conclusion, which I rewrote, and we're still in the middle of it now. So we don't know the effects of COVID-19 on our landscape. I will offer some thinking about COVID-19 at the end of this presentation and some speculations and maybe what we can think about in the future. So what I am going to talk about this afternoon, though, is how this history of American epidemics got us to this landscape we currently inhabit, and what we need to keep in mind as what I would call a real inflection point in time when we think about design, planning, and health. Next slide, please. So the places we live are inextricably tied to our health. Modern day diseases are often a very complicated knot of genetic, lifestyle, and environmental factors. In 2016, Karen DeSalvo, who was then the interim secretary of the US Department of Health and Human Services, noted that public health had entered a new era where one's zip code is a better indicator of health than genetic code. Another thing I was interested in the process of this research, though, is how did our conception of a healthy neighborhood change? In fact, how did we move from this conception of an unhealthy environment being a densely populated urban center, like you see on the left, to a more car-centric suburban or exurban environment, which is decried by many planners, designers, and public health researchers today. And I think prior to the current pandemic, and again, we don't know, what the perception is going to be in the future, but we did see a real shift over the past 150 years in what is considered a healthy and unhealthy environment. Next slide, please. And you can see it in these books. So this is some of the literature of the 70s up until the early 90s, right? And we see these books talking about 6 cities, the urban crisis, the diagnosis and cure, to the logical endpoint of Mike Davis's dead cities. However, around the time that I started this research, could you go to the next slide, please? The more recent literature is happy city. Okay, so building healthy places, people habitat toward the healthy city. Again, why did this conception change, or what are the larger, how did popular opinion shift? Where were people moving to? Who was moving to those places to change that conception and to really concentrate, again, sort of on the city as a place of not just resilience, which we talk about tonight, but of health specifically as well. Next slide, please. So I would posit now that in response to epidemics, we can see the marks of the different ways that we understood how disease spread. And today I'm going to talk about 3 specific eras that I also talk about in the book. And I think there we can see this change from concerns with miasma to then germs, and then built environments that were shaped around changing of behavior. So next slide, please. And I'll start with miasma, which is probably a history that many people on this call are familiar with today. Hippocrates on airs, waters, and places really connected the health of the environment to the health of those that inhabit it. His writings describe the difference between wholesome and unwholesome waters, an unwholesome or unhealthy water being marshy and stagnant. And he talked about those that would drink from those waters as having the possession of large and obstructed spleens. Their bellies are hard, emaciated, and hot, and their shoulders, collarbones, and faces are emaciated as well. Miasma theory had wide acceptance well into the 20th century, most notably in the form of what we would call miasma theory, which associated tangibly foul air and water to airborne disease, a phrase which probably sounds familiar and I'll talk about in the end as well. Next slide, please. So the first movement really connecting the built environment to population health correlates with the beginnings of American urban history during the Industrial Revolution. As factories and workforce populations grew in city centers, so did the amount of waste and sewage dumped in the streets. Slaughterhouses were often still inside city limits, there was no municipal sanitation, and of course, air pollution choked many of these cities as well. Next slide, please. And also many housing units lacked indoor plumbing or sufficient light and fresh air. There were massive outbreaks of cholera, typhoid, and yellow fever in the city, which required coordinated action between planners, engineers, public health officials, and doctors in these fields. Now, of particular concern were crowded tenements. This cartoon, which was featured in Frank Leslie's illustrated newspaper in 1865, was entitled "The Tenement Houses of New York, How the Poor Live in Crowded Cities, How Pestilence is Generated, How Parents are Demoralized and Their Children Depraved, the Great Source of Destitution and Crime." Social scientists who were just beginning to explore the connections between environment and behavior would often point to physical density, physical occupation density as a risk factor for what they called moral contagion, as well as disease spread. Next slide, please. And so cholera became ever more correlated with the generalized urban condition, especially regarding dense housing. So here we can see cholera depicted as a skeleton telling the landlord of a tenement that he is about to occupy the premises. Tenements were routinely described as perpetual fever nests by the sanitary surveys that were done in many cities at this time. Next slide, please. And so the biggest changes came from the first and biggest changes to our landscape came from the installation of massive sanitary infrastructure in the United States. It was during this time that many of the combined sewage, wastewater, street runoff systems were installed in cities, including, of course, Boston, where we work, although we have some of these separated systems as well. Urban waterways or open waterways, which not only had served as waste conveyance, prior to these municipal systems, but were often also where worker encampments were contained in underground culverts and paved over. Marshlands were filled in not only to get rid of their so-called miasmic gases, but it had the added benefit of accommodating industrial expansion, which was happening in cities as well. Now, the outfall of these waste systems was still often in an open water body, but it was at least moved out of the city. And many subscribe to the idea, as Martin Molosi called it, the solution to pollution is dilution. And now it is interesting to see that a lot of these systems are still in place today. And even when these systems were being installed, it should be noted that a significant body of scientists and doctors actually did not believe that disease was spread through the air anymore. In fact, they knew that cholera and yellow fever were waterborne diseases. But what we can see is the effect here is a multi-pronged strategy of personal and municipal sanitation, which also sought to alleviate density in the city. And in the process of doing so was often remaking or removing industry and worker housing. And all of this together really radically remade American cities. Next slide, please. This is a page from an 1895 edition of Harper's Weekly, and it compares photos of the same street corners just 2 years apart to show what incredible transformation street cleaning had affected. Waste infrastructure really configured the streets of cities. Not only were they paved over, as you see here, but oftentimes they were made to be longer, straighter, and wider to accommodate the waste infrastructure. There were some accounts that even some people thought cobblestones were hold to thought miasmic gases in between them. And so some of them were switched out for a smooth pavement that could be washed down at the end of the day. Next slide. And at the same time, in the United States, many planners were looking to Europe to see how they had controlled their own cholera epidemics, which had hit those cities earlier. And then specifically looking at, in the installation of this underground infrastructure, how could you remake the streets of cities and the layouts themselves? Richard Sennett in the book Flesh and Stone discusses how many 18th and 19th century European cities would prioritize circulation and movement via their street networks. And that came in the wake of physician William Harvey's discoveries about how the heart powered blood circulation. So dirt and grime were thought to clog healthy airs that could otherwise spread through the city. Places of commerce and palaces were thought to be hearts that would power movement through the city. And there were the employment of one-way streets to maintain fast movement and mimic the directionality of veins and arteries in the body. Next slide, please. And I think we can see those ideas carry over, probably most notably in the Plan of Chicago by Daniel Burnham, which of course has very direct European precedents. Next slide, please. And with streets and sanitary infrastructure transformed, there came this other sort of graft of, healthy green open space that came to cities next. Frederick Law Olmsted, who was the designer of Central Park, and of course the Emerald Necklace, again here in Boston, actually also served some time as the executive secretary of the US Sanitary Commission. And his time there convinced him that density and slum conditions were the root causes of disease, and that disease could be carried through the water, but also through the atmosphere, in effect subscribing to this miasma theory. Central Park and many of his other parks were able to sort of capitalize on this fear of airborne and waterborne disease, as well as the detrimental health effects for the larger city. And he used this emerging evidence at the time to really advocate for the health benefits of green space, not only for what it would mechanically do to the air and the streets, but in a great bit of foresight, he also talked about the value of parks to provide a mental health respite from the busyness of the city. Next slide, please. And again, very forward-thinking of what we would call sort of park ecosystem services today. In 1870, Frederick Law Olmsted, in his speech on public parks and the enlargement of towns, wrote, "Air is disinfected by sunlight and foliage. Foliage also acts mechanically to purify the air by screening it. Opportunity and inducement to escape at frequent intervals from the confined air of the commercial quarter and to supply the lungs with air screened and purified by trees and recently acted upon by sunlight, together with opportunity and inducement to escape from conditions requiring vigilance, wariness, and activity towards other men." Next slide, please. Health, and specifically the search for fresh air, was in fact a large driver of the move to Western cities like Phoenix and Denver, which grew significantly, specifically by reaching out and recruiting people suffering from asthma and hay fever. Dr. Charles Dennison's Rocky Mountain Health Resorts, written in 1880, advertised Colorado as the Switzerland of the Americas, evoking images of its clean mountain air, but also the generally accepted superior moral values of Europeans. This map by Dennison attempts to show the climatic patterns of Colorado, specifically its dry, cool air. And of Colorado Springs, he said, "It is the home also of a cultivated class of people who have been attracted to the state by health conditions." It was estimated that up to a quarter of people who settled in Colorado, Arizona, and California in the late 1800s, oh, sorry, next slide, please. And very early 1900s did so for their health or a family member's health. Ironically, agriculture and increasing irrigation supported plant growth in the future, and many developed allergies to this new plant growth that was coming up alongside the development. But by 1890, Denver had grown by almost a third, with almost 30,000 people moving there to treat consumption, and this rate of growth would persist for the next 3 decades. Next slide, please. And so in the next era, germs and how that affected the built environment. The commonly accepted ideas and movements about how environment affected health were really upended with the development of vaccines. And the immediacy of infectious disease abated somewhat, although it didn't stop many architects and landscape architects from exploring how this new era of germ theory would affect their designs. Knowing that the pandemics of the early 1900s, namely the flu and tuberculosis, could be addressed by medicine, density was no longer as immediate a concern as it was before, But the thinking about how architecture could optimize bodies and health was still a fascination to many. Next slide, please. Concepts of health and built environment had become mostly theoretical at this point, and earlier ideas about miasma combined with developing building technology, also in a fear of the street as more and more auto use came into practice, really inspired this next era of design. This is the Radiant City, designed by architect Le Corbusier, a mostly hypothetical proposition. But here he was taking some of the traditional ideas from the Garden City and really trying to make it vertical. Like many of his contemporaries at the time, Corbusier sort of feared the pollution and the danger that was coming from cars on the streets. And so in his designs, he really envisioned the street, or the sort of spontaneous interaction you would get on the street, as moved to hallways and stairways inside the building. And Corbusier thought by doing this, he would liberate his buildings from the urban grind, from the urban street. Next slide, please. And so Corbusier's machines for living are really intensely focused on what the right measurements are for an individual, and thought that a community would be made simply by reproducing those units over and over again. In his writings for this hypothetical Radiant City, he specifies that there should be 14 square meters per occupant per cell, which is what he called the housing units, that there should be 12 meters of plate glass window to let in the exact amount of sunlight for optimum health, that the air should be at 64.4 degrees Fahrenheit, that there would be 8 liters of air to go through the rooms every minute for what he called exact respiration, that there would be 1,000 people per hectare, and that a residence would walk no more than 100 meters to transport, and that could be elevator or taxi. And then he also wrote in the book that only 50 meters above ground level is where you could access pure air, which sort of begs the question of who lived below 50 meters, but it wasn't addressed in the book. Next slide, please. And so while Corbusier actually only has one built work in the United States, and of course in Boston at the Carpenter Center at Harvard, we can see the influence of his writing, but also the European Consortium SIAM, which he was a part of. Actually, it's been adopted in many public housing units built in the mid-century. However, without the context of the European social safety net, many of the ideas that he pushed, such as extreme density to keep green space around the buildings, reimagining the corridor as a place of social interaction, and perhaps what was most detrimental to the people that live there was, or at least socially, not the most detrimental. There were obviously lots of things that are just detrimental to their health, but notably this aesthetic disruption and separation from the existing context in which these people live ended up stigmatizing many of the people that were living in these public housing units as well. Next slide, please. And these mixed metaphors of bodies and cities were also wielded to ruinous ends in the mid-century. Concurrent to these movements was when cancer was becoming an epidemic that researchers soon realized could not be conquered by vaccines. There was actually a federally funded early 1960s study that attempted to inject hundreds of monkeys with human tumors in a desperate effort to pinpoint a cancer germ, but to no avail. In Susan Sontag's Illness as Metaphor, she confronts the late 20th century era's preoccupation with cancer by comparing it to the previous TB epidemic, saying, "Now it is cancer's turn to be the disease that doesn't knock before it enters. Cancer that fills the role of an illness, experienced as a ruthless secret invasion, a role it will keep until one day its etiology becomes as clear and its treatment as effective as those of TB have become." Next slide, please. And so the unknowability of cancer is what made it so terrifying, but also made it an apt way to communicate the direness of the urban condition and spur action. Of course, the concurrent epidemic of urban disinvestment, disintegration, and abandonment, commonly referred to as blight, often lead on cancer as a metaphor, especially as it appeared to similarly eat cities from the inside out in the form of fire, vice, and crime. At this time, geographer Michael Deere once wrote that the process of abandonment as it operates in space suggests an initial broad scattering of abandoned structures, characterized internally by the occurrence of many small groups of abandoned houses. It is essentially a contagious sequence, and contagion has major implications for our understanding of the dynamics for abandonment and for later policy considerations. And this treatment of blight as a disease also extended to its documentation, where many cities would go door to door and record the conditions of blight, much like John Snow had recorded cholera incidences on his map several decades earlier. In 1951, Architectural Forum magazine advertised slum surgery in St. Louis, and it blighted and obsolete districts beginning to encroach on the rest of the city grid. The former districts shaded as if to erase their existing characteristics, but again, to communicate the possible contagion of urban blight across the city. Next slide, please. Similar to how blight maps had been used, an educational film from 1953 entitled The Warning Shadow used X-ray animations to depict the terrifying growth of a small black dysplasia on a man's lung. The film ends with the patient agreeing to a pneumonectomy or surgical removal of the lung. Eradication by surgery or radium was the preferred treatment for disease. Next slide. And architects and planners also seized on germ theory and the sort of total removal treatment as a model for how blight should be treated in cities. Now, prior, many municipal departments, aided by private companies like the RAND Corporation, had first attempted immunizations, such as increased municipal services, including fire and police stations, and attempted to enforce stricter building codes in certain neighborhoods to combat blight. But when this failed, they turned towards a sort of urban chemotherapy, and that was the total eradication of clusters of blight. In his book, The City, Its Growth, Its Decay, Its Future, Elo Saarinen used a diagram of the disintegration of cells to discuss the disintegration of the fabric of the city and used a healthy cell as a model for rebuilding. Saarinen wrote, "The slums he clears by piecemeal mending, and the old infects the new in short order. The planner must know, as well as the doctor, that when the head aches, the stomach might be out of order. And the planner must be aware of the fact, as well as the doctor, that vitality cannot be transfused into a dead organ. The dead organ must be removed and the transfusion effected in a healthy part of the body. He must unearth the roots of evil. He must amputate slums by a decisive surgery, and he transfuse vitality only into those areas that are protected against contagion." Next slide, please. And as they had in the sanitary movement as well, children were invoked as innocent victims in order to further the cause. James W. Follen, who was the commissioner of the Urban Renewal Administration, in a talk entitled "Slums and Blight, a Disease of Urban Life," showed Gussie, which is a cartoon depiction of a waif-like young white girl, as proxy for the deadly effect of slums on human lives. That's taken from the book. She's introduced standing on a pile of rubble, or what the book calls adrift on a sea of blight. And the book has a series of maps overlaying juvenile delinquency, lack of sanitation, tuberculosis, and population density, and noted that the densest occurrences of disease always point to the center of cities. Later, Gussie is shown wielding what's called the gargantuan broom of code enforcement of health and sanitation to help clean up the city. Next slide, please. And so to address this issue, urban renewal documents from New York City to San Francisco depicted strikingly similar landscapes, sleek, sterile towers on a flat platform of green. San Francisco's Jackson Square plan is shown as isolated from any, which you see on the top there, isolated from any existing fabric, save for City Hall, with no mention of the Fillmore neighborhood as a cultural center for the West Coast small Black population. We should note that 80% of those removed by urban renewal were Black, and in Baltimore, the number was reported to be 100%. The logic of blight as disease was eradication, erasure, and reoccupation with a healthy graft of anonymous towers in green. Next slide, please. And that brings us to design trends for health just before the pandemic, which I would argue were more geared towards shaping behavior. The reason for that is because I would say, the disease that was the preoccupation of architects, landscape architects, and planners at the time, next slide, please, was the combating of obesity. The Centers for Disease Control reported that in the United States, the percentage of overweight adults hovered around 31% between 1960 and 1994, and the percentage of adults categorized as obese increased from 13% to 23%, meaning almost 55% of adults in the mid-1990s were overweight or obese. In 2005, it was estimated to incur over $190 billion, or almost 21% of all US healthcare expenditures. Researchers started to draw connections between larger patterns of change in society, ranging from food availability and to technological attachment. Next slide, please. But a great deal of the literature started to point to sedentary lifestyles as well, which was encouraged by the unabated suburban growth oriented around the automobile as a driver of the epidemic. By the end of the 20th century, the locus of disease would shift from the cities to the suburbs. The previous figures notwithstanding, the definition of obesity is still problematic in many respects, from the unreliability of the body mass index, or BMI, and its relationship to overall health, to cultural and racial ideals of bodies and diets. Nevertheless, many designers and urban planners saw an opportunity to elevate their practice in the name of public health once again, instead sometimes exacerbated these health inequities. However, on a related point, many also correctly pointed out that car-centric design exacerbates climate change and urban heat islands, which also represent a larger existential threat to all of our health. Next slide, please. And so one movement that came about to try and inject active transportation and combat obesity along many other sort of late 20th century societal ills was New Urbanism. Two of the founders of New Urbanism, Andres Duany and Elizabeth Plater-Zyberg, were planners and the primary architects of Seaside, which is often seen as the purest distillation of New Urbanist ideals. The New Urbanism movement was based on highly specific urban and architectural code to build neo-traditional neighborhoods, preoccupied with density formulas, land use, and most of all, the architectural form of the dwelling, with less attention to the overall landscape, other than ensuring walkability. In their manifesto, Suburban Nation, which was published by Duany, Plater-Zyberg, but also Jeff Speck in 2000, the authors made many assertions that were, common sense, especially regarding how much of the American landscape was only navigable by car. However, when enacting their suggested remedies on the ground, they became almost immediately problematic. First of all, in their steadfast belief that the old way of building was best, they emphasized the historical blind spots of building for social change. Next slide, please. Duany, Plater-Zyberg's urban codes were what could be called a prescriptive landscape, and written not just to address obesity, but also made the claim to improve social cohesion, civic participation, and above all, eliminate cars from the public realm. The early New Urbanists were also particularly taken with regional interpretations of European architecture in the Deep South. Duany and Plater-Zyberg have cited that their inspirations came from a road trip to towns such as Savannah, Charleston, and Natchez, Mississippi, but almost never referenced the racial, social, and class systems that were inherent in these different forms of dwelling. Most of all, building to such prescriptive guidelines was very difficult to enact within existing tables of sprawl, and instead many new urbanist communities were relegated to being built on green fields and far from job centers, and so in many cases only increased it, or in the case of Seaside, became communities of second homes. Next slide, please. However, the willingness of governments to invest in the supposedly curative effects of New Urbanism became apparent when in the mid-1990s, it was adopted as a standard architectural and planning style of public housing under the Clinton administration's Hope 6 development plans. Hope 6 did attempt to take some lessons learned from a disastrous mid-century modernist public housing developments, proposing a scattered site strategy that would strategically infill often slightly higher income neighborhoods with smaller scale single or multifamily housing. But just as in the mid-century, the tactic of adopting a specific aesthetic for public housing, even though it was neo-traditionalism instead of modernism, still served to visually stigmatize those within, while continuing to imply that those living in it could have their health, or by extension, their morals, corrected by architecture. And so really, while it was more a failure in administration in both eras than the design itself, the well-documented effects of displacement wrought by the Hope 6 program as old high-density units were torn down to build new but less numerous mid-scale ones was probably one of the largest detriments to residents' health. Next page, please. Nevertheless, the built environment is still widely viewed as a treatment for the epidemic, extending from the figurative prescription of new urbanism to, in 2015, as we see here, literally being prescribed by the US Surgeon General in their Step It Up campaign, and recognizing the very car-centric built environment that we live in. And I think to provide an environment that supports this is by all means positive, but it will take a lot more to sort of untangle the situation that we're in. Also, as cities and walkable environments have become more in demand, these ostensibly healthier and greener neighborhoods have also become less affordable. And so I think most of all, especially as we go forward and whatever happens after COVID-19, we need to interrogate the idea that at the same time, the design, planning, and even public health community kind of denigrates the built environment of the suburb. Much of the United States lives in that type of environment, and also they are becoming much more racially and economically heterogeneous than they had in the first part of the 20th century. But perhaps, moreover, we need to rethink the idea in the United States that where we live is a free choice, or that it always reflects one's ideal lifestyle. But this is also sadly appropriate for a country that has always conflated wellness with personal responsibility. Next slide, please. So I wanted to end, just by maybe offering some maybe half-formed thoughts or ruminations on COVID-19, as we're still very much in it and we're still understanding what the effects are. I think in the past year and a half, it's actually been like watching a century of health and disease theory pass by in the course of a year. And most of all, what I would say is I hope, as we could see from this talk, that our conception of healthy places changes with medical knowledge in different pandemics. But over time, what we have seen, what does occur, is that healthy places are often only for people that can afford them. Now, all these fears, miasma, germs, and behavior have been made urgent again with COVID-19. So we know now that it is an airborne disease. It is in the air. We sanitize our surfaces to get rid of germs, or at least we did a lot in the beginning. And of course, we're always gradually changing our behavior to socially distance, quarantine, or whatever the best recommendations are at the moment. And at the same time, I think we can take lessons from that many of the ways past epidemics were addressed in the urban environment have also proven to be consistent to today's pandemic. We know that green space is essential, sanitation is key, and the design of where we live is crucial. Next slide, please. And so what I want to offer here is not how design might change as a result of coronavirus, but maybe, some of these, but think more about some of the underlying notions and some of the unintended effects of these movements. And, I don't think, hopefully, I think we're already seeing some of these trends that were coming about early in the COVID-19 pandemic have already passed. That's how quickly it's happened in the past year and a half. Next slide, please. What I would caution us against, though, is that the other consistency between all the periods I've talked about here is that every epidemic, and probably the most misguided of built environment cures, has always affected immigrants and communities of color most acutely. And of course, this is a country that's founded on the removal of its indigenous people, who were first decimated by epidemics, by colonizers, and then systematically and forcibly moved off land they had stewarded for decades, while settlers celebrated their unspoiled quality and built resorts and cabins there for their own health. This painting by Thomas Cole celebrates the American landscape that we associate with fresh air and water and health, devoid of man's pollution. Next slide, please. But sublimates in the foreground here and blown up the solitary figure of a Native American man hidden in the bottom foreground of the picture, and the absence of his tribe speaking as much as his hidden presence. Next slide, please. In this cartoon from Puck magazine, cholera was conflated with newcomers. The title of this piece, called The Kind of Assisted Immigrant We Cannot Afford to Admit. Cholera is depicted as a skeleton in vaguely Middle Eastern clothing. And over time, instead of taking consideration of the poor as a population vulnerable to disease, instead, they have often been blamed for the contagion that rocks our cities. And then they have been systematically removed and quarantined, whether it's physically or economically, but also been subjected to architectural experiments that were built on narratives and metaphor rather than epidemiology or backed by social safety nets. Next slide, please. So I think it's important to realize also how health has been used as a lever for these policies of exclusion and even segregation. In fact, a 1922 housing covenant for Silver Spring, Maryland read, "For the purposes of sanitation and health, no owner will sell or lease the said land to anyone of a race whose death rate is at a higher percentage than the white race." Germ theory and the language of quarantine was also extensively used in Baltimore's residential segregation ordinance of 1910, which kept the Blacks from moving into blocks that had a white majority of residents, even when a series of coordinated actions by the city had excluded Black populations from healthcare access and neighborhood improvements. And in San Francisco's Chinatown, disease was used as a justification for the Department of Public Health to repeatedly raid and even shut down the neighborhood's boundaries. And medical inspections and largely fabricated assessments on the immigration hub, Angel Island, were also used to keep Chinese out of the city altogether. Next slide, please. And so we need to consider how health has also been used to exclude groups from desirable landscapes, or how it even conscribes them to continued landscapes of risk. A recent study from a group of University of California researchers argued that we need to reckon how these social practices and policies can have long-lasting physiological effects. By overlaying the mortgage company's redlining maps with health data, they found that not only were these neighborhoods still largely occupied by communities of color, but that there remained a plethora of environmental hazards from air pollution to high lead content in the soil, which resulting among other disparities in health, a 3 times higher asthma rate in the Black population than whites in the Oakland area. Next slide, please. The effects of climate change, most notably fires, flooding, and urban heat islands, which we've all been thinking about more this summer, will also disproportionately affect communities of color, who are often bereft of urban tree canopies or green space to mitigate some of these effects. Next slide, please. And we must also remember that the most celebrated healthy landscape, Central Park, which was designed by a revered landscape architect, an abolitionist, and a former public health officer, was actually built on the remains of Seneca Village, which was a thriving African-American settlement that was nonetheless written up as a squatter camp in many newspapers and made to look squalid and pestilent in the popular press in order to build support for its removal for the park. Next slide, please. And so instead of thinking about decontamination rooms or plexiglass desks, perhaps we need to be asking ourselves about the conditions that cause these urban heat islands and air pollution disproportionately in communities of color, which have now proven to be underlying causes for COVID mortality. Instead of worrying about the conception of a very specific type or a very specific aesthetic of walkable and bikeable density that has dominated urban design discourse for the past couple of decades, we should also concern ourselves with crowded housing for frontline workers, the forgotten densities, as was written by Canadian urbanist Jay Pitter, and examining if they have equitable access to green space and public transportation as well. We should ask ourselves what it is about suburban neighborhoods that have seen spread that's just as virulent as we saw in cities in the beginning of the pandemic. The environment does not cause or cure disease, but rather it is a key factor in either providing opportunities for health or creating the risk of debilitating illness. We do know now, though, that the landscapes we inhabit do eventually embed themselves in our bones and organs, and some pathways are known and some not. In her essay, Shifting Sites, landscape architect Christina Hill discussed how in culture and ecological science, we long viewed our skins as a boundary between us and the natural world. But it's only recently that we've seen our skins as permeable to energy, materials, and organisms. And now we know the burdens of an inequitable social system as well. That our bodies can accumulate illness, but it can also accumulate resiliency over generations. And so as we endure this crisis and understand that there are others ahead of us, let us take what we have learned from history and use it to shape a healthier future for all. Thank you.
Well, thank you, Sarah. That was spectacular. And I can't imagine anything more timely, given where we are as, we're probably at a period of time, I think, not just once in a generation, maybe once in my lifetime, here where we're going to see, and we are seeing significant resources at the local level and the state level, coming out of the rescue funds and recovery funds, the Congress, and then a really stepped up effort around infrastructure that Congress will probably eventually pass. And so there's this opening potentially for transformative development. The Biden administration has certainly made addressing issues of equity a top priority, as well as climate adaptation. If you had a few minutes with President Biden right now, based on what you know, what would you perhaps give him as basic guides for how to think about not repeating mistakes from the past to get us to a better place?
I mean, I think just as was hopefully shown, as with any intervention, is who is most affected by it, but also who needs the most help right now. And I think that's been the issue, right? Is that ultimately these changes in the built environment really, and knowing also that improvements around health can, spur other unintended effects, most notably gentrification. Actually, in the book, I go into a little bit more detail. Some of you may have heard of this, but the WELL building standard, right, which has been used for many office buildings, and they purport to be LEED for health, so it's health guidelines for buildings. But most of the buildings that have been built under the WELL building standard are offices, right? Which I also think is like a group that we maybe spend a disproportionate time talking about with, although I'm really interested to see what happens, with the switch to remote work, what happens to our landscapes. Sorry, I'm going over my few minutes, Joe Biden, going off on a tangent again. But just quickly, I wanted to say, that when people think about design for health, a lot of people point to the WELL building standard, and Delos, which is the company that administrates it, is now trying to build the first WELL community, which oddly enough is in Tampa, around some of the sports arenas, but also a bunch of healthcare facilities there. And it's just starting to open now, and already, the rental prices in this WELL community I think are over 200% of what the usual rent in Tampa is. So, sorry, I went off on a tangent. The short of it is first of all, who is being most affected, right? Not only in the past, but who will be affected by these issues in the future. And then I would also talk about how health is the intersection of all of these things, that infrastructure, infrastructure changes, adaptive climate changes, that health is central to it. And I'm really happy that, they've reestablished, or maybe established, I'm trying to think what went away with the Trump administration, a health climate change unit at the CDC that they're looking at. I think we tend to think of these things as sort of like different emergencies, but health is really where they all intersect. And obviously the Department of Health needs to be on board with those changes as well, that they are not separate.
Great, thank you. Others who have questions for Sarah?
It's hard to frame this as a singular question because it's so broad, but obviously when we talk about resilience, we're always talking about including every structure and every system that you can to make it inclusive, but which is really what you were talking about, how everything is connected. You have social equity, the built environment, health needs to be involved. Like how do you suggest getting everyone on board when we are adapting our urban landscapes that already exist and building new ones, when you need the input of so many of these different sectors to make sure that you avoid being, it has to be environmentally friendly, it has to consider health, it has to consider gentrification and
right,
doing good by the people that already live in the space.
Yeah, I think actually you said it last, is that's probably the first place to start, is understanding like what local needs are, because they're going to change. There was a really interesting walkability study that was actually done by Arlie Adkins, who I think is at Arizona State, I'm not sure. But he was looking at, talked about walkability at the end, and he went to different communities around Tucson, I believe, and in white neighborhoods when he asked like what qualities of the street would make you walk more, and it was very much about physical amenities, right? They talked about benches, trees, etc., that would make a street more walkable. In going to some of the lower income and Hispanic communities, safety was much more of an immediate issue. So just safety crossing the street. And I think that's also something I'm trying to get across in the research, is that health is not a broad brush, right? Like a health solution for one community, another community may have very different health issues. And so I think the priorities have to come from the ground up, but keeping some of these sort of basic principles in mind that, you know, for a lot of vulnerable communities, basic safety, basic, you know, clean air and water provisions, soil provisions need to come first. And that's often forgotten when we talk about health and design, where we're sort of thinking about this, you know, idealized Main Street America, but there's very many sort of acute environmental factors that we need to look at, especially for communities that have been excluded from these sorts of talks over time.
Great, thanks for that. Kishore, did you have a question?
Well, just a question of, I'm fascinated by what you had to show and where we're going. One of the things that we always worry about, resiliency of the buildings from a civil engineering point of view, and you stayed at Tulane, so you went through a couple of hurricanes just to realize. And ultimately what happens in these plans and so on are good, but ultimately the individual buildings are built by developers,
right,
businessmen, and they're dependent on the building code, which is always, as soon as you put a force into it, saying it has to be a certain amount, then it doesn't always get built the way it should be. So that we don't get the resiliency that we hope to get. And it ultimately boils down to behavior of the people. So how do you project behavior of people? And then we are finding that right now is we all think everybody should be vaccinated, but then people are not, and it's the behavior of people. So how do you change the behavior, or how do you project the behavior?
Yeah. So I would say another anecdote from New Orleans, you know, right, actually before many people came back, there was a plan that was issued partly by the Urban Land Institute that showed a map of New Orleans, and in the most low-lying areas, they just had big green dots, right? And they said, this is going to be a park when everybody comes back. But it was a circle that was out of scale with the neighborhoods. It didn't align to any sort of topography, you know, even though they just knew there was a low-lying area. And there was so much outrage in it. And I remember in a couple of years after Hurricane Katrina, there was so much pushback that they basically just abandoned any kind of these like really rigid plans, right? And people were just building back wherever. And some people were raising their homes 10 feet off the ground. And then there would be a whole block of empty houses. And so I think part of it is, and this might be, again, and this is just from a background and something that teaches in public engagement, so it might sound a little bit wishy-washy, but just, you know, trying to empathize, I guess, where people are coming from and sort of their values, that there's a lot, especially in the United States, is that there's so much tied up in residences, right, and where people live and their neighborhoods. And that has been, this sort of displacement has been detrimental over time. That's not to say, like, I think we do need to think more about, say, managed retreat, right, and where we should be building. But you can't just do it and not have a plan to place and also help the people that you are removing thrive in the places that they live. The anti-vaccination question is, it's nuts to me. I'm trying to empathize. I'm having a hard time with it now, you know, just because I come from quite a rural area of the United States, South Dakota, which is having a terrible time with COVID. As much as I'm trying to empathize with that view, I'm trying to have a hard time. And I would, you know, I think the biggest roadblock we have to get over is this is an illness that is going to affect everybody. Like that does have an effect on people. And I think we've gone so far in thinking about individual freedoms, though, that we kind of have to negotiate that. So again, I don't know if it's an answer specifically to code in your building, but I would just say a lot of these top-down sort of proposals, though, where you're just moving people or just showing them land where you can't build anymore, there needs to be a little bit more thought to in a system, right, to place some other places as well. The other thing I would say is, I mean, it's hard to put hedonic costs to it, but the thing is climate and health is going to cost us more money in the long run. Then I think there's some pushback from developers, saying to building towards a resilient code or building for health or planning, for the long-term health of residents is too expensive, or you have to do too much. But the thing is we're wasting lots of money now. We're wasting lots of energy because we have, a built environment that you can only drive, right? Or you're going to be building in places that are going to be flooded anyway. So I think that's the other part of my response is like, we need to take a harder look because the money speaks to developers, right? Money speaks to developers most of all, and these things are going to cost us in the long run.
That's great, Tara. I guess, and a great way to finish here. We look at, from the Global Resilience Institute, how do we address the barriers to resilience in sort of 5 lanes. First is you're not going to get more resilient if we don't promote essentially risk literacy, understanding how risk and hazards impact on things, not just us, but things that we value. And secondly, we don't design for resilience. We design off for efficiency and low cost and those kinds of things. Safety when we're told to, kind of things. And you're obviously really helping us, stretch those issues. The question just raised, even if we have good designs, how do we have the economic incentives to adopt those designs? Right. And then most of the solutions will have to essentially span cross communities. And so you get into jurisdictional public policy questions. And lastly, we got to train and educate people to think in a much more integrated way than we have traditionally done this way. So bottom line here is we're not likely to be successful at tackling these problems if we don't really truly take a multidisciplinary perspective, and that we also really do it in a way that we're co-learning with communities and exactly how we develop these solutions. So I think your book speaks clearly to that. Your presentation today does offer many insights that will hopefully guide these efforts. Really grateful for your spending the hour with us here, and glad we've caught this and recorded it, and hopefully we can make it more widely available afterwards. And thank everybody for participating here as well. So the conversation will continue. Right.
Thank you, everybody.
Okay, have a great day.
Thank you so much. Thanks, Kathleen.
Thank you.